A Healthier You, Making Diabetes History on Guam.
Presented in partnership with Calvo Select Care and Paradise Fitness Center.
All right, everybody, welcome back to The Link on this Friday. And we saved the very, very best for last because, as you know, all week long we have introduced you to learned professionals, people involved in the insurance industry, in medicine, in education, in treatment, and in diagnosis of diabetes, certainly a disease that has touched the lives of many, many island residents here on Guam. And we have brought them to you, their insight, their perspective, their expertise, and now we are all joined here together as we do on Guam, gathered around the table, if you will. It's an early Thanksgiving here on The Link, and we have a special town hall, and this is completely interactive, everybody. So if you have any questions whatsoever about diabetes, about the validation study we're going to talk today here, or anything about the treatment or anything under the sun about diabetes, please put them in the comments below on Facebook, and we will be happy to entertain them for you. So we will be talking about the validation study first, but let me go ahead and reintroduce some of the fine people we have here. All the way from Calvo Select Care right here on the island, of course, my good friend Frank Campillo, the plan administrator over at Calvo Select Care. Frank, always good to see you.
Thank you, Jason. Happy to be here this morning.
All right, good to see you. And let's now go to Mighty here on the island, where Dr. Dolores Lee joins us again. Dr. Lee, already a celebrity here on the show because, Doc, your segment was very, very enjoyed by our local community here, and they said they really appreciated the fact that you empathized and you said you take a you can relate to your patients, and people really took that to heart. And they said, I really understand the disease better and how we, it's not just one person going through it, but their entire peer group, their family, their church, what have you.
Thank you so much, and just always happy to help out my community in any way I can. So thanks so much for having me back. Mananasitos, buenas, and healthy.
All right, and can we get a Join Your Rules again? Do you just want to rep your village?
Join Your Rules.
There you go. All right, so and we hope all of Jonia is tuning in right now. Dr. Erica Alford, also a local physician, a very well respected one. Daka, what village are you from? I didn't get a chance to ask you last time.
Good morning. I actually grew down the street from Dolores.
Oh.
From Dr. Lee. We were in the same neighborhood.
Okay. Do you want to give us a Join Your Rules as well?
Join Your Rules.
There we go. Outstanding. And now let's go stateside, where we're going to head to the mainland. Let's go out first to Hotlanta, the ATL, as the cool kids call it, where Dr. Francisco Pascal, an esteemed physician and someone doing a lot of work with technology and with the diagnosis. Doc, always good to see you, and thank you for returning.
Thanks very much. Good to see you again.
Okay, now let's go out to what they call the left coast, out to Los Angeles, where Dr. Juan Espinoza is there. Dr. Espinoza is, of course, deals with pediatrics. He also talked to us about a lot of what's coming up with treatment and the study of data. So, Doc, good to see you.
Hey, it's great to be here again. Good to see you.
Okay, do you guys want to rep your high school, or what town you grew up in? I mean, since we're all about civic pride here on the show, you're more than welcome.
We've moved around so much. I don't know what I would call. I think LA is my hometown. It's the place where I lived the longest.
There you go. Well, my sister and my brother are in LA, so I've got a special place for the City of Angels in my heart, certainly. And now let's go kind of upstate to the Bay Area, where an esteemed professor, physician, and someone who has really made a lot of pioneering work in the field of diabetes, Dr. David Klonoff. Doc, welcome back to the show.
Oh, nice to be here.
All right, and I guess I'd like to start by just saying, Doc, I ordered your book on Amazon. I've been reading it all this week, and it's a very, very accessible book. You guys, please go out and get it. Diabetes, Digital Health. There you go.
Feel free to quiz him.
Yeah, I've got it on Kindle, but the one thing, I mean, it's a very honest truth and also very sobering at the same time. As you say, literally in the foreword of the book, is that the largest groups of people that have diabetes in the world are in China and India, but it's Pacific Islanders who have the highest prevalence rate. So maybe to contextualize what we're going to talk about today, can you just maybe give some opening statements about that statistic?
Yeah, diabetes can be a real problem for people. It's associated with various complications, higher incidence of heart attack, stroke, kidney disease, blindness, amputation. So anything people can do to prevent diabetes is a very good idea. And if a person has diabetes, then by living a healthy lifestyle, eating healthy, exercising, people can do a lot under control and take the medicines as prescribed, and people can do well with diabetes if people put the work into it.
And here on Guam, we've kind of talked about this all week long about the prevalence of diabetes here on our island, and it's what 1 in 6 have diabetes on island. And so I wanted to just start to give our community just awareness about and what this is all about, the AI Health Guam validation study.
Yeah, sure. I would be happy to take that one. So the mission of AI Health is how can we use artificial intelligence, data, and technology to support people and communities to achieve their best health. And where we wanted to start with was diabetes as something that is a global issue. And it's also a disease that disproportionately affects people of color, ethnic and racial minorities, and lower income individuals. And so there was a huge disparity, and we felt it was really important for us that was a place to start. And what we're hoping to accomplish with our study, we're thinking of our study in 3 different phases. The first phase of this study is really just understanding if we can look at known data, so patients who we know have diabetes and we know what's happened to them over time, can we get from that, can we develop algorithms that might be able to predict the future, right? Can we predict who's going to have a complication, who might need a transplant, who might have a heart attack, who might have a hospital visit? Once we do that, looking at what we call retrospective data, so data that already exists, then we want to move, okay, now let's do it prospectively. So looking forward, let's follow people into the future and see if we can, as we get data in real time from them, how does that change our algorithm? Can we move that? Can we use that to fine tune the algorithm even better? And then the third and really the most exciting phase is great. We found a signal. We can predict who is more likely to have a complication, who might do better with a certain treatment. Now what? What do we do for that person? How do we actually help that person get better? Is it a different treatment? Is it a different medication? Is it a nurse coordinator, a social worker reaching out, helping with recommending diet and exercise? That's really the crux. The data and the algorithms and the artificial intelligence, that is just a vehicle to help us get better treatment to people so that they can experience better health. And so that's how that's what we're trying to do at AI Health. And really our partnership with the community here in Guam is so critical to do that, because it requires trust. We have to work together. We need to understand how diabetes affects people here locally and what they can do about it here locally. It doesn't do me any good to develop this algorithm in New York City and then say, oh, right, great, here, it works in New York City, you use it. Mm-hmm. It doesn't work that way, because communities are different, people are different. And so we really wanted to be able to demonstrate that it can work here, and from here, and say, great, now let's try to globalize this. Let's take this somewhere else and see what else can be done. But we're really excited about the possibility of doing this type of work here in Guam. It's kind of a perfect setting to do that. It's a very diverse community. It's not too big, not too small. We can capture enough patients to really get the information we need, and we can identify really all the partners that we need. Calvo Select, GRMC, AMC, Public Health, the governor, public awareness campaigns, like working with Guam on doing this together. We can build a really nice community and really achieve this goal together. Right. So we're really excited to be here.
And you said, like you said, the partnerships are key. And so I wanted to throw it over to Mr. Campillo to talk about the partnership with AI Health to make this study a reality.
Thank you, Sabrina. Well, our mission as a health insurance plan is to help our members improve their lives by offering them several health and wellness tools to address some of the critical issues that they have. And diabetes, as you know, is a critical issue, especially in our island. We are number 10 in the world in regards to the incidence of diabetes, and as Dr. David was saying, the Pacific Islanders are especially have especially high numbers. Marshalls is the #1 country in the world in regards to the incidence of diabetes. So based on this mission, it was very easy for us to work with AI and try to get this algorithm validated for the island. And what we're doing is we're providing data in our members that have diabetes, and see how we can get this program going and see how we can help the island. And at the end, they help our members, which is the most important mission that we have.
I'd like to kind of bring Dr. Pascal into the fold, if I might, because Dr. Espinoza, I think you touched on that beautifully, is, the importance of having diverse data and, not being able to say, we gathered a sample of, say, 10,000 patients, and then we're going to apply that, worldwide, because very often that approach will not work, especially when it comes to like the stratification of different patients and everything. But Dr. Pascal, you mentioned in our segment the other day how important it is to have AI models that are truly like unbiased and have a wide range of data so that they can be more effective.
Well, absolutely, and the new technology it's superior to the typical models that we have used in the past, where there's different ways and mathematical ways to do it, and the same with AI. There's several different ways and alternatives to introduce those predictive models, but I think using all the information that we have from patients, from the data, getting the information from the individual patient at the individual level, getting the information from their sensors, for example, getting information from the clinic visits, and getting all that information together will help us have a better understanding of the actual situation of each individual patient, as opposed to just going back to getting some demographics and making some decisions on underlying characteristics of patients that really are not telling us the whole truth of what's going on with our patients. So having all this ecosystem of data and being able to integrate that into a personalized approach, I think is going to make a big difference. There's obviously a lot of issues with biases in previous algorithms and racial biases that have been reported before, and I think this approach has the potential to eliminate those.
Yeah, and we've heard, the instances of data sets being biased, perhaps, like for consumer products, like, Google's got like, 7 or 8 different times when they say, they may have had an image classifier that was supposed to identify apples, and it actually said, oh, like a banana is an apple and everything. It's a trivial example of that, but when you're actually dealing with human patients and people that could be sick, it's a completely different like environment that you're playing in, and obviously way more sensitive.
Yeah, and the issues about insurance coverage and all those things, there have been a lot of issues and complaints before about how people are identified based on their background and how the insurance coverage may change just because of that. So this is really relevant, and moving forward, I think there's an opportunity to change the way we visualize care.
I think there's a really important thing that Dr. Pascal is touching on, which is this concept of ethical AI. Right, ethical artificial intelligence, right? That we should be doing this in a way that truly helps support all people with a lens of equity. And when we think about artificial intelligence, it's not that machines themselves are the bias isn't from the algorithm, right? Ones and zeros aren't racist, but machines learn from what they're taught, like kids. And so, the classic examples in machine learning are facial recognition software that were trained to recognize faces on a bank of 1,000 photos of only white men. Then all of a sudden, when they see, for example, a black woman, it doesn't know what to do. Yep. And so we as humans who program AI and who develop AI, we introduce bias into those systems. Or we might introduce bias because we say, oh, this feature, this data element, let's say, income level or ownership of a car is what's important. And really that's, to us, what that's telling the system is to pick up on that data element as being important, but that data element really is just a proxy for something else. Maybe it could be race or socioeconomic status or something else. And so again, our biases as humans, when we apply those and they get incorporated into these algorithms, And then the beauty and danger of these algorithms is they can be applied at scale. So now all of a sudden you're not just making biased decisions on one person, you're making biased decisions on 10,000 people at the same time. Mm-hmm. And so that's the danger of artificial intelligence and why that approach to really ethical AI is so critical. And you know, you can be ethical in how you train it, you can be ethical in how you program it. You also have to be ethical in how you use it and in how you share it. One thing that we're really looking forward to in partnership with all of the other organizations in Guam who are really helping us, JRMC, Cal and AMC, is over time starting up a forum where we want to have community events where we want to share progress. Like, this is how our study's going, these are the numbers that we're getting, and this is what it's looking at, because we want the community, you know, this community this is your data. These are your lives, your patients, your family members. And so you have a right to know what we're doing with it. Mm-hmm. And so one of the things that we're going to start coordinating with is hosting regular opportunities for the community to have an insight into what we are doing with that data, and provide a chance for updates and a chance to provide feedback so that you can tell us how you think we're doing with what is very much your data.
Mm-hmm. And, you know, for GRMC, they're serving as the internal review board for this study. And Dr. Alford, if you could kind of talk about your role as the principal investigator.
Hey, yes, absolutely. So I am one of two endocrinologists in Guam. And so my role in this study is being the clinician on the ground with the patients and the patient base to help facilitate the study, as we always need the patients in order to make a study successful. I must say our patients on Guam are amazing. They're always willing to help, and I learn from them on an every single day basis. And so they may say that they learn from me a lot, but the amount of education I get from them is absolutely amazing. So my role in this study is mostly as the clinical endocrinologist practicing in Guam with the patients and the local expertise about diabetes in Guam.
I know earlier this week when you were on the show, you were it was kind of show and tell with the glucose monitoring devices that you were, you know, featuring. So I'm just kind of wondering if those continuous glucose monitors, if they're going to be used as a part of the study.
Absolutely. The best way to get good glucose data is to get continuous glucose data, because point in time testing only gives you a small picture. So the plan is absolutely to use continuous glucose monitoring as part of the study.
And Dr. Lee, if you could talk a little bit more about your role in the study as well.
I actually don't have like a direct role in the study, but in terms of a provider who takes care of patients with diabetes, you know, in partnership with the other partners in the study. And so I know that, you know, my patients will be part of the data set, and really just, I think my role will be promoting, you know, just the positive relationship that we have with everyone who's directly involved in the study, and thanking our patients for being willing to be part of it. You know, as Dr. Alford said, we have an amazing community here. You know, patients are always willing to help out, especially when we think about the fact that the end result is something that is going to improve our community in some way. And I really appreciate, you know, that Dr. Espinosa acknowledged that the data belongs to our people. That's really important, you know. So I think, you know, my role would be, you know, again, continuing to take care of patients in partnership with Dr. Alford and with, you know, the other partners in the study, and really, you know, just promoting like what the purpose is, and, you know, and thanking our patients for being part of it.
Okay.
That's I just want to say that is a critical role, because you know, patients face so many pressures in that. There's work, there's family, there's their finances, just their free time. And sometimes participating in research just doesn't become a priority for a bunch of very good and understandable reasons. And so having partners in the community who are always encouraging, who are supportive, who are helping to answer questions goes such a long way in helping research studies be successful. So it's something that we're incredibly grateful for.
I think that is a hallmark of the Guam community, you know, and I think anybody here would agree that our people always do what we can to step up. So maybe, ladies and gentlemen, if anybody wants to like jump in, how can people be candidate for being included in that population of the data set that will be generated?
Yeah, so for the first part of the study, we're using retrospective data, so data that's already been collected over the last 5 years by AMC, GRMC, and Calvo Select. So that part of the data, that one's easy on people. You don't have to do anything. Where we will be recruiting patients to participate in the study is in the second phase, where we'll be following patients moving forward, and we'll be recruiting patients to participate from the practices and clinics in Guam. So working with providers like Dr. Lee, and of course with our PI, Dr. Alford, and our partners at GRMC to identify patients who are eligible and who are willing to be part of our study. So that will probably start later next year, while we're still doing the first phase where we're looking at the existing data.
Oh, okay. Because I'm sure there are people like myself where, diabetes has a tendency to run on my father's side of the family. I have been tested, multiple times, and I'm 47, but they said, you're okay for the moment. But I'm sure there are people like me that would say, based on my family history and, hereditary and everything like that, I may want to contribute if I'm able.
Yeah. No, that's wonderful. And one of the things that we started doing as a result of this partnership that we have with you and your team is putting together a website with resources just on diabetes in general, educational resources, learning resources, community-based resources. And so we hope that website is something that the Guam community can turn to and depend on, and it'll be a place where we can share updates on our study, but also just access to great recommendations on healthy living and exercise and care that you can access in Guam. Because the whole point of when we talk about lifestyle management for diabetes, your lifestyle management has to fit your lifestyle, and your lifestyle is in many ways dictated by the fact that you're here, you live on Guam. So great, what can we do in Guam to help manage your diabetes?
Okay, that's a perfect segue, Doc, because I wanted to bring Dr. Klonoff in for this next question, because when it comes to lifestyle, Dr. Klonoff, I want to say when we did that piece with you the other day, when you talked about the system that will basically be use the wire and the ball, if there was like in the little microscope that is Guam Twitter, I think wire and ball was trending because everybody was like, wait, no more finger pricks and no more needles and everything. Everybody was on board with that. So when it comes to this type of wearable technology, how do you, as someone who's done pioneering work in this space and everything, how will that impact the lifestyle, the quality of life, and the healthcare of the patient? And can you speak to how it might also economically, like if there might be like cost to that?
Right. Well, the wire and the ball is a way of describing a continuous glucose monitor, which is a tiny, flexible wire. It's made of plastic. It doesn't hurt. It sits under the skin, and there's a little ball at the end of it that sends a message wirelessly to a computer, and a person can look on the computer or on their smartphone, see what the blood glucose is. It turns out just about everything we do will affect the blood glucose. Raise it a little bit, might raise it a lot, or lower the blood glucose. And when a person is wearing a real-time continuous glucose monitor, they can see what are the activities they do that raise the glucose, which ones don't. When I give one of these to one of my patients, I'll say to them, what's the worst thing that you can eat? And I get comments like cake, ice cream. Let's say ice cream. So, okay, ice cream. I want you to go eat some ice cream. See what happens to your blood glucose. It's one thing for the doctor to say ice cream raises your blood sugar, but another to see what it really does. And people will discover certain foods agree with them and certain foods don't agree with them. There are other kinds of sensors that we'll be using in this study that will make other measurements that affect a person's health. We want to be able to give recommendations to people which activities work best for them to keep their body functioning normally.
So it's basically like real-time proof of concept to saying, okay, well, you ate that candy bar and everything like that. Did you see your levels spike?
Exactly.
No, I'm sure that Dr. Lee and Dr. Alford, who have absolute pulse of the community when it comes to people, and like I said, our people rise to the occasion, but we're also known as we can be pretty stubborn. So, like, ladies, if you would, offer from a clinician standpoint and everything like that, when people have kind of like pushback or maybe they don't immediately like buy into a system, what will this technology mean as far as really convincingly driving home that point of, here's why you have to take care of yourself because this is the impact of that?
Oh, that knowledge is absolutely important. I'll take an example. I just saw a new gentleman a few days ago threw him on, I was like, let's get you on a CGM, got him on the Dexcom. And as of yesterday, he's on about half the amount of insulin that he was taking just 4 days ago. And his blood sugars have stopped spiking and dropping, and they have been tightly controlled in the last 48 hours. It's absolutely amazing what that little bit of information can do for a person.
Definitely, I have to agree, both as a clinician, as somebody who takes care of patients with diabetes, and then, as you know, I live with someone with diabetes, right, my dad. And so, one of the things that is, like I was saying on Monday, education is key. We want patients to be able to better understand their condition and how their actions impact their condition, right? And that, a great majority of my role is to help patients understand that so I can empower them and give them the confidence to make good choices, and I have to say that, when I pair the glucose monitoring with asking patients to keep a food journal, and asking them to be honest about what it is they're eating, and they see that correlation with how what they ate impacts their sugar, they make that change. They eventually make the change, right? In terms of because they want to see that their sugar's in a better place. And I'll give it to you from the standpoint of my dad. If he sees that he eats a meal and his sugars shoot up into the 200s, 300s, 400s, which is a place definitely where he does not want to be, he's going to modify his intake of that the next time. So I think definitely, I always tell patients that, I'm not asking you to monitor your sugar because I'm trying to burden you or I'm trying to make you feel bad. I'm actually asking you to monitor your sugar because I feel like it's going to help you to understand what you're doing, how it impacts your diabetes, and it's going to empower you and help you and encourage you to be able to make better choices for yourself.
Does that kind of break, that cultural, like I said, I said pushed back or, being stubborn and everything like that, but there is that kind of like cultural barrier where if someone younger than you is trying to impart, knowledge, it's like, oh, you can't say that because, respect your elders and that whole thing. But when you take this approach backed by data, hopefully that is in real time and everything like that, does that really prove the point?
Definitely for patients who are willing to make the change, right? And again, I have patients who will tell me straight out, I just don't like checking my blood sugar. I would prefer not to know, doc. And I would just tell them, I'm like, and honestly, I'll appeal to them in any way that I can. I'll be like, could you at least humor me and do it for at least a week? Can you do it for any amount of time here? I work with them to get them to that place. But of course, patients have to be willing to be there, right? And eventually, and I think the key is relationships, I know both Dr. Alfred and I have shared, our stories that we have patients who honestly just like to come in and just talk to us. Are they really going to follow, any of the recommendations we're making? Maybe not. But, I know Dr. Alfred and I both agree. We're thankful that patients are willing to come see us. And I think we express that gratitude whenever we do see patients, and that just helps us to build on the relationship. You're right, in terms of I do have Madame-Co patients who refer to me as girl or Nenny, and I take it because I realize that's it's not meant to be condescending. It's just it's meant to be affectionate, and the most important part is the relationship, because if I tell patients, if you're not willing to come in and see me and at least willing to have the conversation, then I can't do anything for you. And so I think, Dr. Alfred and I both agree, we continue to, keep really good relationships with our patients, keep them coming back into our office. And I want to say that even with patients who are initially hesitant, like my father, because Dr. Alfred has helped my dad, like my father, who are initially hesitant, they eventually will make the change, because, consistency, like a consistent message and a good continuous relationship with patients will help us to get there.
I did want to ask about going back into the study. I know it's focused on diabetes, but will you also be gathering data with regard to COVID?
That's it's a great question. We definitely, part of the study is understanding what are the comorbidities or other conditions that patients have experienced. So one of the data points that we will be collecting is, did a patient have COVID? We won't be studying COVID specifically as part of this study, but certainly we've had the opportunity to speak to the governor, and I know that there are others on the island who are interested in how this technology might be used for other conditions like COVID. And so certainly those are things that we're interested in. And I think both Dr. Pascal and Dr. Konoff earlier this week talked about how COVID uniquely affects people with diabetes and how their outcomes can be in many ways worse than other patients.
And I think, and we've talked about, these systems and the wearable technology and what it means to have that kind of, rapid response data and see the results of that very, very quickly from the patient's perspective. And Dr. Pascal, you made the point very strongly the other day during our segment, as you said, from the physician standpoint, being able to remotely monitor, is very advantageous to your profession.
And I think it's not just for the doctors following the patients remotely in the hospital, the patients with COVID, for example, which is what we've been doing recently, but it's also the ability of caregivers, family members, to be able to follow up on their patients. So I think there's the technology is going so fast that I don't think there has been yet an opportunity to develop all the training material for patients to learn how to use CGM. Because many patients may be just using the technology to just look at the glucose instead of looking at with the finger stick. They'll look at with the machine, but not necessarily interpreting the data or making predictions of what's going to happen. So I think it's also an opportunity to look at engagement. I think as the phase 2 of the study continues to develop, looking at engagement, asking patients, what are the things that they don't like about the technology, they don't understand about the technology, how can we teach them better to use it effectively? I think that's also going to be an important part, because sometimes the most disadvantaged patients, sometimes patients with less resources, are more likely to discontinue the use of technology. So I think that's also another area that we may consider exploring.
It's been reported that the rising costs in Medicare, Medicaid are impacting the quality of healthcare. What impact could a platform like AI Health have to help address these costs while improving care?
I think a benefit of these treatments is that we will have some specific recommendations for people. Rather than say something might work, we'll be much more likely to know that it will work, and we won't waste time and money. I'll give you an example. If you have a pill that works in 50% of patients, then you know that some of them are going to be getting their money's worth and some aren't. But what it really means is that in half the patients it works all the time, in half the patients it doesn't work at all. If we knew who they were, we would save time and money just using it on the right patients. The type of data that we're going to be collecting in this study will allow us to make a precise assessment of the patient, what's wrong, what's right, and select a treatment that's very likely to work. So I think that will save money.
Yeah, Frank, I'm assuming you have some insight that you can give to this question.
Well, absolutely. And some of the information that has been discussed regarding to why it's important to bring this to the islands. For instance, some of the examples that were even used by our panel makes it more important that we realize we need to bring it to the micros, to the islands. For instance, Dr. David used ice cream as one of the staples that somebody will say, go eat ice cream and see what happens with your glucose. In our case, we will say, go eat Spam, because that's the popular staple in our island. So that's the important reason why analyzing the social economic statuses, what people eat, the different type of food intakes are important. But yes, we as a company, we provide coverage for the CGMs. That's something that we started doing just recently, something that we're working with Dr. Erica to get our members more used to this type of devices. Of course, there are certain qualifications. They're not for everybody, but those individuals that are meeting those qualifications, I think we're getting them. Dr. Erica, I don't know if that member that you were talking about earlier was our patient, but clearly we began working for your team to provide these CGMs to our members, and we continue promoting them, and hopefully we're able to get more real-time information so we are able to control the diabetes and improve their lives easier and quicker. And in regards to the study, yes, having the data, having more information about what our population does. Something that as simple as whether our population walks 6,000 steps or 10,000 steps a day. That's something that will bring the difference between what kind of medications can be used for those individuals. Because clearly exercise, for instance, is something that also affects the way how medications are overall digested and overall applied to individuals. So we look forward to continuing with this study and continue supporting AI health.
And I'm so glad you brought that up, Frank, because I think Calvo Select, when you guys made that decision, before we were ever, we didn't know each other when you made the decision to start making coverage decisions for CGMs, is, CGMs certainly have a cost associated with them. Depending on the brand, they're a couple $100 all the way up to $600. But what Calvo Select and insurance companies like them have realized is that's okay. It is worth spending that money, because improving the cost of healthcare, reducing the overall cost of healthcare isn't about giving people less healthcare. It's about giving them the right healthcare they need. Because what's expensive in healthcare is the hospitalizations and the emergency room visits and the ICU and the surgeries. And so if we can give them the care they need, access to, say, a technology like CGM, or access to a nutritionist, or access to a social worker, right? If we can give them the care they need, then we can prevent them having to access the care that's very expensive, the ER, the hospital, the ICU. And so I think the CGM is just one tiny microcosm of how insurance companies are starting to think about, well, let's give people tools that, sure, they cost us money now, but they're going to prevent us from having these bigger expensive. Not only are they expensive for us, but they're catastrophic for people.
Mm-hmm. So in a way, and maybe Frank would probably quite literally, this is insurance, and it's insurance for your health.
Well, in a way, we provide tools to our members that are going to improve their lives at the end of the day. And by improving their lives, hopefully there is a cost reduction. And when we talk about diabetes, I don't know if you know this, but even in this infrastructure bill that was signed by the president, there are huge amounts of money there for diabetes, because it has become such a catastrophic disease in America that we realize we got to get ahead of this disease. Otherwise, it will be economically unaffordable for the country.
Mm. I wanted to talk real quick, maybe Dr. Alfred can speak to this. When it comes to the continuous glucose monitors, these CGMs, I realized that one thing I forgot to ask all you wonderful people over this week was, where exactly is it administered, and how often does it have to be, does the system have to be replaced, if at all? I mean, because does it always is there an advantageous part, like maybe on the arm and the chest close to the heart, or could I do the fashionable thing and I'll have a piercing on the nose if I want to be one of the cool kids? Or
Piercing in the nose.
I mean, that would look great in 2005. Maybe in 2021, not so much anymore. Fashion changes.
My apologies.
So it is brand specific. There are some manufacturers where you wear it on the arm. There are others that you wear on your abdomen, and depending on the device, they get changed out every 10 to 14 days usually.
Oh, okay.
Yes. And we're supporting the one that is wearable in your abdomen, the Dexcom one. The Libre, which is produced by Abbott, is wore on your arm, but somehow it appears that because of the way how you move your arm, the frequency of disconnection of that particular seems to be greater than the one that you wear in your abdomen. So we support the Dexcom, but both are equally as good. There is great progress over what used to be before with the glucose monitors, where you had to prick your finger. So that also improves people's lives. At the end of 20 years of people pricking their fingers, they really are not able to even have senses in their fingers, because those nerves have been basically killed by all the pricking that you do. So this is another way to improve people's lives.
I agree, Frank, because my dad did the finger pricking for like almost 8 years and everything like that, and it was hard for him to type on his smartphone, after a while, just because like you said, his fingers got pricked thousands of times. I guess another thing I didn't ask was, when we talk about the stratification of these devices, are the devices equally effective on maybe young children as well as the elderly, or is there a specific type of that kind of system if you're a young person who has diabetes?
Yeah, so we've actually been using the continuous glucose monitoring technology has been in use with children with type 1 diabetes for a very long time. And each of the manufacturers, so the FDA regulates what age group is appropriate to use different devices. And so the main manufacturers, Dexcom, Abbott, and Medtronic, all have pediatric indications. I think they all go down to about 2 years of age. But yeah, so they certainly, we use them in children. Really, they're across the lifespan, and there's good data both from clinical practice and from research studies that shows that they're safe and effective in children as well as in adults.
There's even recent preliminary data that they may be helpful in preterm infants. And it's just incredible how it's being applied to the whole kind of population in general, because it can be beneficial. I don't think it's for everyone. At some point, some people demonstrated that there's even no need to do some finger sticks in patients that may be taking just one pill for diabetes, just like metformin, and their glucose is fine. So maybe all that information is probably not needed for them. It's just also becoming a choice. But the evidence so far is that for patients that use at least basal insulin in general, tends to work. Patients on basal bolus, it works. Patients with type 1 diabetes, it works in terms of improving glycemic control. And the other part that is not very well understood is like the component of behavior, because it's a little bit more difficult to assess. But it's now really a behavior modification tool. Because the patient is, as David was saying, the patient is interacting with their own data in real time, and they're getting the feedback immediately. So I think learning how to interpret that data, and hopefully most patients will learn that and will benefit from it.
I wanted to go back to the study, and if you could kind of talk about like the duration of the study, because you mentioned next year you're going to start recruiting people to participate. So how long are you going to be gathering the data?
It's a great question. We want to get at least a minimum of 12 months of observational data from patients who agree to participate in the study. If we can get more, we will. But 12 months is a big commitment, and we want to work with individuals in the community to understand how do we make this more palatable, more acceptable, so that it makes sense to stay enrolled and to continue to work with us. But our goal is to get at least 12 months of data for every patient that agrees to participate in our study. And agreeing to participate in our study means that we're gonna give you the sensors, so you'll have access to them. We will provide you with a mobile application that'll help collect the information on your behalf. Patients will sporadically be asked to answer some surveys and just provide some information about their behavior, right? Their physical activity, their diet. We also are really cognizant of the impact of stress and mental health on diabetes and the control of your blood sugar. And so we'll have some questions around that. Our goal is not to make this intrusive, but hopefully that it's something that sort of fits with your overall care plan of sort of taking care of yourself and being healthy. There aren't any interventions, so to speak. If for anybody out there who's participated in a research study, sometimes say, okay, well, to participate in the study, you have to come to the hospital on this day and we're going to do these things to you. That's not really the kind of study this is. This is really live your normal life, and every now and then check in with us on this mobile app, answer a quick survey. Is it okay if we look at your sensor data? So we try to make it not obtrusive and not get in people's way, so they can still lead their lives while they're doing the incredibly important work of giving us an insight into the data that can help tune these algorithms so we can use them to predict how to help people better with their diabetes.
Thank you for sharing. Oh, I'm sorry, Dr. Colano, please.
Something I say to people that are thinking of enrolling in a study like this is that many people who are adults have a family history. And that means that their children or nephews, nieces, grandchildren, or children of friends are likely to develop diabetes when they get older. And if someone who has diabetes now takes part in a study like this and provides data that we can use to create better treatments, then those treatments might be used for one of their own relatives.
Mm-hmm. And thank you, Dr. Espinoza, for bringing that up, like the privacy aspect, because I can already anticipate, like in getting back to ethical AI, Every time a conversation like this comes up and data says, like people just go on the internet and they read, oh, somebody's going to use your data for something. It's going to be used for advertising or whatever. Like if I participate in this study, Facebook's going to start sending me ads and everything like that. So I'd like to give you gentlemen and ladies, the opportunity to maybe just dispel any myths about, about privacy, about security, or things like that I'm assuming have already bubbled up.
Yeah, no, it's a great question. So medical research under U.S. legislation is very strict in what kind of data you're allowed to collect and what you're allowed to do with it, and more specifically, what you're not allowed to do with it. But the legal and regulation part, that's just the stick, right? Like this is what happens if you do it wrong. We also have the oversight of the IRB, the Institutional Review Board at GRMC, that's overseeing the conduct of the site. We have to submit to them our protocols, what we plan to do with the data, where the data is going to be housed. And again, going back to our commitment to ethical AI and transparency is, we will make all of our documentation, not the data, publicly available. So anybody who wants to know, I want to know where my data is, great. We will tell you exactly where it is. Patients who at some point decide they don't want to participate in the study are able to leave the study at any time and have their data removed or purged. We take healthcare data security very, very, very seriously. We use incredibly complex and advanced cryptographic algorithms to protect data and to de-identify data so that there's no way even if somebody were to have a breach into a data center, there's no way to tell that, that patient is you. So this is something that is incredibly important to us, especially for a team and a company and a product that's based on data. If we can't guarantee the safety of our data, what can we guarantee? Right. So we take it incredibly seriously, and it is a trust. We think of ourselves, we are stewards, right? This doesn't belong to us; it belongs to you, and it is we have the privilege to be able to use your data and work with your data. And so it is our responsibility to then keep that data safe so that you're safe.
And Dr. Klonoff, you were actually featured in Wired magazine for your thoughts on data security at the device level, so even dealing with the hardware.
Yes, a device could be susceptible to a security breach, and I'm currently working with the International Electrical Engineers Organization to create a cybersecurity standard. And we're also working with FDA, who will, I believe, recognize the standard when we're finished. There's three kinds of problems that could happen if a device is not secure. There could be a lack of confidentiality, and someone else could find out the records, or maybe the data isn't available when you want it, or maybe it could even be changed. Fortunately, the products that I've seen are pretty good at security, but security is an escalating field, and we have to always make it better. A standard will give manufacturers an idea of what they can do to really be sure they have good security. But the products we use are known to have good security.
Oh, thank you.
Dr. Lee and Dr. Alford, have you already begun having these conversations with your patients about the upcoming validation study? And if so, what's been their feedback in terms of wanting to participate?
Absolutely. And I think a big thanks is to both of you, because they have heard about this study and they were interested and they've been asking questions. So I've broached them that when the time comes, we'll discuss enrolling them in the study. And so far, I've gotten very positive feedback from all the patients I've discussed this with. Thank you.
I'm just, I'm again, like I said, I'm as a community provider, I'm just learning about the study, and I definitely work very closely with Dr. Alford. And so we've, had a chance to discuss it. Already in my mind, I'm thinking about some patients that I'm willing to approach because I think that they will be a good fit for the study. And, like I said, I'm very hopeful, just because it's always been the response of our people in the past to have this willingness to contribute to information that is going to help our people and help our community. So I'm very excited about it, and I'm very thankful for the opportunity.
All right, very well. So we are almost out of time, but we'd like to give each of you doctors and those of us without MDs at the end of our name, maybe the opportunity to maybe give some final thoughts about why people should participate in this. I mean, I don't see any reason why anyone would not to. It's good for our community. It's good for society. You're actually helping mankind by doing this, and you're taking care of your family as well as yourself. So we'll start with Dr. Francisco Pascal with your final thoughts, please, sir.
Absolutely. I think we're all together in this fight. It's concerning that at some point we were believing that the rate of obesity and diabetes was coming down. And then suddenly in the last couple of years, we started seeing that curve started going back up. So it's really concerning, particularly in young people. So I think prevention is the most important. We've learned with the pandemic that we are just trying to patch things as opposed to have preventive measures. So learning from the community, understanding what is going on in the community, seeing where we can improve, I think that's extremely important. So participating in the study will allow the community to understand what is going on at the individual and population level, so we can find better solutions for the health of the community.
All right, thank you, Doctor. Okay, Dr. Juan Espinoza, if you would, please.
Yeah, I think one thing that I'm just super excited about in this study is that it's certainly, at least in my career, the first time that I've been involved in a project that is truly a collaboration across every sector. I mean, we're working with hospitals and healthcare providers in Guam. We're working with Frank and his team at Calvo Select as an insurance provider. We're working with Dexcom, who's the manufacturer of these devices, who's going to be the devices that we use in our study. The governor's office has been incredibly gracious in helping us think about how we collaborate with public health officials, and that's fantastic. Like, that does not happen in healthcare. So we're incredibly grateful and lucky that we get to do that. We get to do that in Guam. But the reality is, even if we line up all those ducks, the most important partner is the community, or the people who are going to participate. And it doesn't matter what we do with everybody else. If people don't have the trust and the interest, and if we don't earn that trust and that interest, then all of this is for naught.